Hey everybody, welcome to this edition of 5 Minutes or Less of EMS, which gives me a pause. I want to walk you through something because I've gotten some feedback recently. So the name of the channel is 5 Minutes or Less of EMS because I needed something kitschy, right? You know, short. And honestly, a lot of the original videos were 5 minutes or less. I really was intentional about that. But this is an update. This is the May 1st updates. There is no way to make this 5 minutes. And honestly, for those of you out there who don't know, if you're watching this and you're in Sacramento County, you may or may not be familiar with the state regulations. The state regulations and the county policies say to get an hour of CE, it has to be 50 minutes. So I'd be happy to change the channel to 50 minutes or less of EMS, but I'm fearful that people wouldn't come back and watch the shorter ones because we will put some shorter ones in there from time to time. I think you and I are going to shoot one next month. So just be patient, right? This is 50 minutes, but it is an hour of CE, and we hope it brings you some education. We know it takes a while to go through this. You don't have to watch this video all the way through the first time. It's designed to come back and go back and go back. And so, but we want this to be valuable for you and for us. So welcome to this edition of 5 Minutes or Less of EMS. I am your host, Kevin Mackey. I'm the Medical Director of Sacramento Fire Department, and I have a very special guest with me.
Hi there, I'm Dr. Beaver, and I'm the UC Davis EMS Fellow.
So as you know, the county goes through an exercise every year where about every 6 months they've gone through about 40 to 50 policies, and there's sometimes big changes, sometimes not so big changes. We found out with this one that there's a couple of kind of bigger changes, but this gave us an opportunity, since there wasn't a lot, that we can get kind of nerdy.
Lots of science.
Me, nerd.
Journal articles.
I know, journal. You're gonna love it, I swear. But we are gonna go through some of the science because we do get asked questions. One of the big ones is why do we wait 7 minutes to get that 12 lead after ROSC? You're gonna know. Yep. So we're gonna go through all of the science in this, and we hope that this is useful to you. But again, just be patient with the length. I know the name of the channel's 5 minutes. Some of these have to be longer. And I'm not going to rename the channel, folks. So it's 5 minutes less of EMS.
It's too catchy. You got to keep it.
It's kitschy.
Yeah.
All right. So we'll see you in a minute. We'll take it away.
Yeah, let's get into it.
Okay, so we have a special guest with us today. Dr. Kann is our county medical director, and we want to talk about a memorandum that came out on March 13th. So, as many of you know, there's been a distinct change in how law enforcement responds to behavioral health crisis. And this really stems out of a case out of Las Vegas that went all the way to the Ninth Circuit Court of Appeals in an unfortunate case where an individual died. And this was during the administration of medical care with law enforcement on scene. And what happened is the Ninth Circuit Court ruled that there was an infringement on this person's unreasonable search and seizure. So there was unreasonable search and seizure. And there was also potentially a 14th Amendment violation as well. So as a result of that, many law enforcement agencies across the country have begun to disengage on behavioral health calls unless a crime is being committed. And this has put EMS in a very, very peculiar position because we have a duty to act, but yet the seizure part and the gaining control is not part of our regular training. So you came out with this memo on March 13th, and we thought we'd give you an opportunity to kind of go through what you were thinking and talk about the BARS assessment for sure, which I think is new for our audience, and where that all kind of came from, and then we can hopefully set an even playing field and kind of set a stage for what your vision is for how we respond to behavioral health calls. So
fantastic. Thanks for the opportunity, Kevin, and it's great to be here and to have an opportunity to discuss with all of you this very important topic. Just as we sit here filming, we have neighboring counties in our region that are going down the same pathway where law enforcement officials are coming out and saying that we're not going to respond to psychiatric crisis anymore. So it's very well timed that we have this in place to give you, the provider, some coverage and some direction and guidance on how to approach this very difficult topic. So it was about a year ago we looked at policy 8062, which is the behavioral crisis and restraint policy. We understood that there were situations where you would roll up on a 911 call for service and the scene would be unsafe, and we don't want we never want an EMS provider to have to go into an unsafe scene. It's the first thing you learn when you're becoming a pre-hospital provider, scene safety. So we made some policy changes which allowed for you to post up and essentially just if you can be in eyesight of the patient. But the policy had a huge kind of problem with it, in that what happens if that scene never becomes safe? Are you just going to sit there for days on end watching this patient in psychiatric crisis? So we approached county leadership and had some very difficult conversations. And how do we allow our care providers to leave the scene? If that scene never becomes safe, you're not going to be able to just continually sit there and watch that patient. You have to be able to go back into the 911 system. So that's where this policy memo came out of those conversations. It was very long conversations involving the county council, and all the way up to the county CEO and the board of supervisors level. So
I'm gonna just point out there, and I know you said it very quickly, but to get to this point, first of all, this is not a policy. This is a memorandum,
correct,
which was very intentional.
Correct.
And the individuals that have seen and approved this policy is all the way up to the CEO of the county. So there is support out there from legal counsel and from the leadership in the county for what this memorandum says.
Correct. And that's why we're going to go through a very stepwise kind of discussion on how the memorandum applies, and that pathway needs to be followed pretty much verbatim, so that we have the support that you just mentioned.
Right. Yeah. Okay. So there are some steps.
There are some steps. So let's go through that. So again, you mentioned, Kevin, that this is a memorandum that's been put out. It is our hope that our law enforcement partners change their behavior, and at some point down the road we'll start to engage with these patients. And again, we have jurisdictions out in our community in where law enforcement agencies do, and they have a robust response, but the memorandum is going to stay in place until we have a change in law enforcement policy. So this kind of supersedes 8062, or adds clarity and furtherance to policy 8062, and we'll go through that now. So again, just to highlight the fact that this memorandum is intended to provide clarity for our providers on how to proceed in situations where they encounter a scene or a patient that's in behavioral crisis and that scene is unsafe, and that you do not have a law enforcement partner presence. Okay, so the procedure here, and again, it's a very stepwise thing that we need you to follow. So first off, you're going to follow 8062. Okay, which provides the BLS and ALS interventions that you would do on a normal behavioral health call. If you're able to assess the patient, engage, do your exam, take them down the pathway that's listed in 8062. If the scene is unsafe, and that can be from a lot of different ways. So if you get dispatch information that says there's a weapon on scene, or a family member comes out and tells you that they have a weapon, or anything that gives you an indication that this is an unsafe scene, then you don't go in there. Don't engage. You can post up, and then we have to go through the steps here. So per your standard operating procedures, you contact the supervisor that's going to come and help you engage and manage that scene. supervisor definition has been left very intentionally vague in the policy or in the memorandum here, because your supervisor may be different than a supervisor from a private ambulance company or across the spectrum of
or
our
a different fire department.
Exactly.
So
of our
you've left it
stakeholders.
open to define what we think is a supervisor,
Correct.
what we
Correct.
would consider to be a supervisor.
Correct.
Okay.
So that member of your leadership team, you can kind of think of them that way, will help you engage with the situation and to apply the policy memo to ultimately, if you cannot engage with that patient, leave the scene. Okay. So again, you're in a situation that's unsafe. There's a whole host of possibilities, and we don't want to go through everything. We can't list everything out here in a memo. But essentially, if you deem the situation as unsafe, contact your supervisor so that they can help you engage here. Then we're going to go through our steps here. So there are 6 of them. Okay, so we've already talked about requesting that supervision to be on scene. That supervisor will contact their law enforcement equivalent to essentially give them an idea about the situation that is being encountered, and can discuss scene safety and scene safety mitigation procedures, okay, with law enforcement. And at that point, if you get a law enforcement response and they're going to help you, like some of our jurisdictions that exist in Sac County, then you go down your 8062 pathway. But if you do not have law enforcement presence, you continue down the pathway. So step 3. So the supervisor or your EMS leadership is going to document in the PCR that they made that conversation, that they made that contact, they made the conversation, so that we have an opportunity to then follow on all of these situations, what the non-response was.
Yeah.
So,
and this is an important pause to have here to remember that the documentation that goes into the pre-hospital care report form here is essential.
yes.
The conversations, who the law enforcement supervisor, they discussed the elements of the conversation.
And what the outcome was.
And what the outcome was, exactly. And then you're going to hit step 4 here, and it's a very specific procedure that is in our pre-hospital care report forms.
Right. And this is super important, because this gives us the ability to track all of these situations so that we can report it to county leadership, and to understand how often this memo is being utilized. That's going to be critical for downstream follow-up, and to allow us honestly to build our case on how many times this is happening in our community, so that we can start to get a change in behavior.
Yeah. Procedure is?
So the procedure, you need to document a procedure that the police requested to attend.
Yeah, so this would be like documenting an IV procedure, or a medication administration procedure, or intubation. Like, this is an actual procedure that you put in the procedure part of your PCR.
And again, that gives us ability to track it on the back end to know how many times that was triggered. So that's step 4. Step 5 is that in consultation with on-scene staff, so that's EMS leadership, and the provider on scene, you're going to do a BARS assessment. So a BARS assessment is the Behavioral Activity Rating Scale, which is measured from 1 through 7. Okay, so you can think about the bar scale as a continuum. So 4, being right in the middle of that bar scale, is you and me, sitting here having a quiet conversation, somebody with a normal mental status. They're not agitated, they're not depressed, they're right in the middle. If you go down from 4 to 3, 2, 1, you're getting more sedate. Okay, so down to a 1 would be somebody who's difficult or unable to arouse. So these are your altered mental status patient that you're thinking about intubating. Right. Okay, but then the flip side of that coin is going from 5, 6, 7. You start to get more agitated as you move up. So a 5 would be somebody that has signs of overt physical or verbal activity. So you can imagine the person that has psychiatric history, they're schizophrenic, they're on the street corner, they're have internal stimuli, they're talking to themselves, they're maybe waving their arms around. But there's somebody that you walk up to them and you say, hey buddy, are you okay? They'll turn to you and they'll have a conversation with you, and they're calm and they're able to be redirected. So, but then a 6 would be somebody that has that level of agitation, but you try to redirect them and it's not going anywhere. And then you start to step back and say, this scene is not safe. Okay, so the 6 is that person where you start to get the hairs on the back of your neck are standing up that this is not a safe scene. And the 7 is the person that's overtly aggressive, that's swinging at you. Okay, so what we want to be recording is bars scale 6 or above. Okay, as being your criteria to move forward with disengagement from the scene. And I want to provide clarification here. So I've had people ask me about the memo. Hey, do I have to go up and am I this close talking to somebody to do the bars assessment? So if you go up and you knock on a door and you hear somebody that's screaming and in crisis on the other side, you can assess for a bars assessment just how they're verbally interacting with you on the other side of a door. If they're that aggressive that they're a 6 just from your verbal interaction, they're a 6. You don't need to have that hands-on touch kind of exam. Or if you see somebody a block away from you and they're actively aggressive, they're swinging, you can assess the bars assessment from a distance. So I want to make sure that that's clear for everybody, that you can maintain your personal safety and scene safety while still doing that bars assessment. So point 6 of our stepwise pathway here. So if you have a 6 or greater and there's continued law enforcement non-presence, okay, then you may elect to not engage with the patient based on the scene safety assessment. Point 7 in our memo then essentially says that once you followed all 6 of those initial points and you've allowed 30 minutes, we want to give our law enforcement partners a reasonable amount of time to be responding to this scene. If you follow points 1 through 6, so scene supervisor doing your assessment, bar scale, and then you have 30 minutes have passed by, then in consultation with the EMS leadership on the scene, you can leave the scene, return to 911.
Okay. And that bar 6 or 7 is kind of what we were doing in the past, what we considered an unsafe scene, right? Where we're staying a distance. So that's not really a change, other than the fact that we're putting a number around it now.
Yes.
This is a bar 6. This is a bar 7.
Taking it more from a subjective feel to being a more objective thing that we can document. So then, if somebody comes back through the chart and says, "Okay, well, what were you up against?" I've got a bar 6. I've got a mental picture now of what the scene was like. Right,
and if I could just implore with the EMS clinicians that are out there that are watching this, put more than just a bar 6 in your narrative, right? Describe it, paint a picture. Say, I tried to engage with them through a door and they threw something at the door, or they were yelling at me, or they were not redirectable and they continued to display violent behavior.
Right. Right, and that could be in a car, that could be wherever, all kinds of scenarios. But just the underlying theme here is keep yourself safe.
Right. Okay.
Okay.
Yeah. Any other words of advice?
I think we've been given a great opportunity here by our county leadership that is very engaged, and our leadership that understands that EMS provider safety is paramount. And when you have a tool like this, we have to use the tool effectively, we have to document effectively, and because not only does that allow us to stay safe medical legally, but this documentation is going to give us the ability to go back to our law enforcement partners, tell them how many times this happened, to kind of paint the scene of what the overall picture is in Sacramento County, and hopefully affect some change, and to get our law enforcement partners back engaged in this patient population.
Okay. Well, thanks so much. Appreciate you coming by.
Always happy to be here.
All right, we'll see you in a minute. We're ready.
We're ready. 8026, the respiratory distress policy. So the major change to this one is the addition of a new medication called ipratropium, which trade name is Atrovent. In the past, you had always used just albuterol as a nebulized solution for your patients in respiratory distress, but now we have the addition of ipratropium. So when you combine albuterol and ipratropium together, it's considered a duo-neb, which is something that we commonly use in the hospital for basically all patients that are in respiratory distress. Previously in the policy, when you would start a breathing treatment, you would always start with 5 milligrams of nebulized albuterol. But now the difference is you're actually going to change to 2.5 milligrams of nebulized albuterol plus 0.5 milligrams of nebulized ipratropium. Depending on which agency you work for, you could have a pillow that has a combined solution of the 2.5 milligrams of albuterol and the 0.5 milligrams of ipratropium, or you could have them separate. So you could have two separate pillows that you would put the 2.5 of albuterol, the 0.5 of ipratropium into the nebulizer together, and then you would start your treatment. And it just depends on what your agency decides to carry. Now, after you do that initial treatment, then you are still going to continue potentially to use albuterol depending on the level of respiratory distress that your patient is in. But this kind of depends on which pathway you're going down. And so it's really important that you pick which pathway you're going to use. And maybe you can explain a little bit more.
So pick a path. In respiratory distress policy, you're picking either the asthma, COPD side of life, or you're picking the CHF, pulmonary edema side. So in all of them, the very first treatment out the gate, no matter if it's CHF or asthma COPD, your very first treatment is going to be a duo-neb, which is the albuterol and the Atrovent mixed together, either in a packet like Brianna showed you or in doing separate pillows. It just depends upon which your agency chooses to do. However, when you get beyond that, then you're going to be talking about doing albuterol. So let's talk about the asthma COPD side of life. After you've finished your duo-neb, if you're in the mild respiratory distress pathway, you're going to use just albuterol, 2.5 to 5 milligrams. Now this immediately, in my little medical director mind, makes me get a little nervous because we have two very similar packaged medications that are a little different. A little different. So this is the one that we just talked about that has the combined medication in it. This is the one we've always carried, which is albuterol. Once you get beyond this, you're going to be just using albuterol, and depending upon the level of the persistent dyspnea, and if you're mild or moderate severe, is the quantity. So in the mild respiratory distress COPD pathway, 1 to 2 of these. But if you're in the moderate to severe, you're in a continuous albuterol neb side. So what does that mean? That means that one of these is 2.5 milligrams. You could use multiple of these over time. It takes probably about 10 minutes or so to get 4 of these, which is 10 milligrams in. But it could take, it could take longer. But what's going on is that in our county, we have shorter transport times, mostly. But you could potentially get a few of these in if you're in the moderate respiratory distress and you're in asthma COPD.
Yes.
Now, let's pop over to the other side. Let's talk about CHF. If you're in the CHF side of life, you've done the duo-neb, and you're moving next, if you need it, to albuterol, but that is going to still stay 2.5 to 5 milligrams, which is 1 to 2 pillows. So, a little confusing, but just make an effort. Pay special attention to know which one you're using, because we only use this one once, and this one we could use multiple of. Okay, so I'm going to have a little moment of PTSD paramedic education. Right, so why? Right, I love these videos when we talk about the why. And here is why. Albuterol if you think about it, is a sympathomimetic. What does that mean? So the sympathetic nervous system has these alpha and beta receptors, and if you're thinking, what are the ones in the lungs, in the smooth muscle? Which one is it? Is it beta 1? Is it beta? It's beta 2, right? It's beta 2. So albuterol stimulates the beta 2 receptors. It's a sympathomimetic, meaning that it mimics the sympathetic nervous system. And so it causes these smooth muscle dilation, relaxation, so we can get bronchodilation. That's for wheezing. Now, what does ipratropium do? Well, ipratropium comes at this from a completely different angle. It affects the parasympathetic nervous system. It's a parasympatholytic, meaning that it interferes with the parasympathetic nervous system, which in some of these patients, they have a lot of secretions and mucus production, and this really dries out those mucus secretions. So it affects the bronchoconstriction from a different angle altogether, but by drying them out. So, but it should only be used once. It's really only effective once in the hospital. We pretty much only use it once as well. So we have a Duo-Neb that's coming to town, and we still have our albuterol. Pay attention to which one you're using.
(8031) non-traumatic cardiac arrest policy. So the big addition or change to this policy is that if you have a patient who is in persistent or refractory VTAC or VFib, after 15 minutes, you are going to transport that patient to the closest receiving hospital. And so I just want to make sure that it's clear that this is not recurrent VFib or VTAC. This is persistent or refractory, meaning that every single pulse check, regardless of any interventions that you have done, this person remains in VFib or VTAC. And after 15 minutes of that, you need to not that you need to leave at 15 minutes from the scene, but if you decide to transport that patient, you want to make sure that you're going to the closest receiving hospital. And one of the things that we wanted to discuss today was if you do have a patient who's in persistent or refractory VFib or VTAC, one of the things that you could try would be potentially changing the vector.
Really important discussion about what to do with that patient. You just can't get them out. There is a lot of science, and as I warned you up front when we started this video, this was going to be pretty science heavy, which I think is kind of cool. From the geeky, nerdy side of me, I think it's fun. But there is science about how to do this. So I thought we'd share that with you. New England Journal of Medicine 2022, here's the article for you. They looked at a few things. Now, one thing they did look at is double sequential defibrillation. We are not talking about that right now just yet. But what does it mean to do a vector? So in this study, they looked at patients that had persistent refractory VFib or VTAC, and they did 3 treatment arms. They had either just standard treatment, which is what we're doing right now. Then they did a vector change branch, and then they did the double sequential double sequential defibrillation. Right, electrical defibrillation. It's a lot of words. DSED, right? Okay. So there are 405 patients in this study, and I want to bring you some results. So the patients that had vector change and the ones that had double sequential electrical defibrillation, but we're not talking about that.
Not talking about that.
The ones that had vector change actually had a much higher likelihood of survival and success. So what does vector change mean? All right, so you can see in this picture, which was in the journal article, and I encourage you, if you want to go look at the science of this, I'll put the link in the bottom of this video, so you can kind of go to it and search for it. These are all open access. You can get access to them. But here's what they did. So we either have kind of 2 places we've learned about. We've got the kind of the anterior lateral, and we've got the anterior posterior. So kind of the anterior lateral is where a lot of us start with our defibrillation, right? And so a vector change means you're going to change the path of electricity, and you move those pads just a little bit more anterior and go posterior. Now, if you're already anterior posterior, you go the other way, right? And you make it more anterior lateral. And so just changing the way that electricity travels through the chest wall makes a difference. and it actually does successfully get a number of people out of persistent refractory ventricular fibrillation.
Yep.
I'm sticking to it. All right, so let's talk about the post-ROSC care bundle. All right, let's flip to that next. Okay, post-ROSC care bundle. No one said this was going to be easy. We get a lot of questions about this, honestly. I know you field some, I fielded some. A lot of the EMS physicians around the community are feeling like, why are we staying on scene? And why do we have this max dose epi, which is other questions, right? So I thought I'd take a moment to just talk about a patient that has successfully achieved ROSC. They're arguably among the most critically ill patients you are going to manage. And how you manage them makes a massive difference in outcomes. A patient that rearrests in the back of an ambulance after your hard work and effort has achieved ROSC has a dramatically decreased chance of survival, and that's what we're trying to prevent. We're trying to get these patients stabilized. They've just gone through this major adrenergic hurricane that both their own system dumped a bunch of epinephrine into their body, and we dumped a bunch of epinephrine into their body. And so they're in a very fragile and critically ill state, and they're like a house of cards that are just getting ready to crumble. And for no fault of their own, but of our actions, if we're not careful, we can cause a rearrest, and that's what we want to try to prevent. But even with our best efforts, about a third of the time they're going to rearrest. We just want that to not happen in the back of an ambulance. We're going to stay on scene a little bit.
Yeah.
Okay. Yeah. So why don't you talk about what some of this bundle looks like?
Yeah, absolutely. So I think first it's just good to delineate what are the goals of both CPR and then what are the goals of ROSC, right? So the goal of CPR is to just restore circulation by that patient's heart on its own, right? Like we are not doing any external work. The patient is able to restore circulation. And then once you get ROSC and ROSC is obtained, what is the primary goal there? Well, the primary goal there is to really stabilize the circulation that they have achieved by optimal oxygenation and optimal perfusion, right? And so there's a couple of things that are included in this. So the first thing is just going to be managing the airway, whether that's a subglottic airway, whether that's an ET tube and they're intubated, making sure that we are managing that airway appropriately if it was not already done. And then the second part of that is really managing their respiratory parameters. So whatever we can do to get their oxygenation anywhere above 92% is going to be the most ideal for their SpO2, whether we need to do a little bit of suctioning, whether, however we need to optimize that. If we can get them above 92% for their SpO2, that's our goal. And with that is also monitoring their end-tidal CO2. Can we get their end-tidal CO2 goal between like 32 and 35 is going to be ideal, and making sure that we are also monitoring their end-tidal CO2, right? Making sure that we put that in there and we're watching that, and that is a parameter that we are looking at. And then also talking about bagging this patient. What do we want their respiratory rate to be? So initially, I think we want their respiratory rate to be about, 10 breaths per minute or so, which is going to be 1 every 6 seconds. And so really kind of thinking of all of that, managing the airway and managing our respiratory parameters.
Yeah. If you think about this, the first minutes are all respiratory.
All respiratory.
All respiratory. Making sure you've got a good established airway, monitoring your rate, paying attention to your SATs, paying attention to end-tidal CO2. That's the first step, first 2 minutes after you get ROSC.
So after those initial few minutes of managing their airway and managing their respiratory status, then you really want to talk about managing their circulation and potentially their hypotension that they're going to have. So our goal, right, is going to be that their systolic blood pressure is greater than 90. That's kind of our big goal for them. So you could start off by doing a normal saline bolus of about 1 liter or so. But if that's not working, what are some other options that you have? Well, then you can talk about doing some push dose epi. So the push dose epi, you could do anywhere from about 1/2 to 2 mils every couple of minutes of your 1 to 100,000 epinephrine. And you're going to basically use this kind of based off of what your blood pressure is showing you. So if you've given, 1 or 2 mils and after a few minutes they're still hypotensive, give a little bit more, right? While you're potentially simultaneously also giving fluids, if your leader has not gone in yet. So I think those are the big things for managing that hypotension side of things.
Yeah, operationally also,
Yeah.
I always wonder, when we give you a range, like a half to 2 cc's, like what do you do in the ED?
Yeah. I base it all on blood pressure, but I would say that I start big, especially in a post-ROS patient.
I'm so glad you said that because I do too. Right, I do too. You definitely don't want to play catch up here.
Totally.
You do not want to play catch up. So I start with 2.
Yep.
I stick with 2.
Yep.
And there's some people who say, they're so tachycardic. Their heart rate's like in the 130s. That'll come down.
Yeah.
Like that'll come down. That is not their primary problem. It's going to kill them. Their hypotension is going to kill them.
Kill them.
Yeah.
Or put them back into an arrest.
Which we don't want to do.
Which we do not want to do.
Right,
so,
exactly.
Yeah. And then a question that we've gotten a lot about is getting our 12-lead EKG, but why after 7 minutes? And so I think you wanted to talk about a little bit of the science behind that.
More science. Yes, there is science around this too. So I will put some things on the video that you'll be able to see, but this was studied as well. At what point do we get a 12 lead?
Yeah.
After someone achieves ROSC. The name of the study is called the PEACE study, which is kind of cool, I think. It's from just a few years ago, and they timed out getting a 12 lead post ROSC at less than 7 minutes, 7 to 33 minutes, and greater than 33 minutes. We'll just say you're welcome. We're not making you stay there for 33 minutes, right? But 7 minutes was definitely a delineating factor. Yeah. There was a massive amount of false positive STEMI 12 leads within the first 7 minutes of achieving ROSC. And we've already kind of talked about the fact that this massive adrenergic storm has just happened, and you're getting this washout of all this epinephrine. The heart is super irritable, like super irritable. It has just been through a war, and things are just kind of starting to calm down a little bit. So waiting at least 7 minutes, 8 minutes or so, and you've already talked about, like, we're going to be doing some airway stuff.
Yeah.
We're going to be doing some push dose pressor stuff potentially, and it's okay. The 7 minutes will happen fast.
Yeah.
Trust us. The major thing is, do not package this patient up and start running to the ambulance. Take a breath and start getting some of this stuff in order so that you don't have to do compressions on the way in.
Yeah, definitely.
All right.
And then I think we just wanted to give a reminder about our max dose of epi.
Oh, my second favorite question.
To use. And so just a reminder that epi does improve chances of ROSC, right, while a patient is undergoing CPR. But there is a kind of point where it is no longer necessarily going to be helpful and could actually be detrimental. And so that is grams.
It is. And there's even some question out there about whether or not epinephrine is helpful at all in cardiac arrest. And I will say that the science, and we're going to talk about science if you didn't know that already, is that epinephrine for sure helps with ROSC.
Yeah.
I feel like I can get a rock with a heartbeat again if I had enough epi, right?
Probably.
But at what point is it too much? And this delineating factor of around 3 milligrams, there's some systems you may have known about. Seattle, they give a half milligrams. They give up to 6 doses, but they get to 3 and they're done. Yep. And so we have made this dichotomous decision here in Sacramento County to stop at the 3 milligrams. And I just want to read to you the summary, and just so you know, and again, this article reference will be here in the video, but 6 countries have looked at this: Australia, Japan, Norway, France, UK, and actually the US hasn't looked at it. There were 6 papers, 2 of them out of Norway. Norway wasn't convinced with their first one, so they did a second one. These results, so the maximum dose of epinephrine or the role of epinephrine in cardiac arrest altogether is as follows. These results suggest, with these 6 studies, that when comparing epinephrine to placebo, I'll say that again, placebo, that would be giving someone saline. We can't do that in the US.
Right.
Like that's why you don't see the US in part of these papers. But when there is a potential to improve rates of ROSC, there is a potential to improve rates of ROSC. There is at best no difference in neurologic outcomes, and in some cases a potential for worse neurologic outcomes in patients receiving epinephrine in cardiac arrest. Now they make that statement out of the study out of Japan.
Yeah.
They studied tens of thousands of cardiac arrests, and they found that the patients who received epinephrine did in fact achieve ROSC a lot more often, but tended toward a worse neurologic outcome. And we can have lots of science discussions about the effect of epinephrine in the brain and cerebral circulation, but for the purpose of this, for all of you out there who've wondered why we stop at 3, it's a compromise. We're not making you stay on scene for 33 minutes, so you stop at 3. How's that?
Lots of 3s.
There's lots of 3s out there.
Lots of 3s, yeah.
All right, so does that cover our post-ROSC bundle?
I think so.
All right.
I think we can move on.
All right, let's move on to the next one. All right, 9005, pediatric traumatic cardiac arrest. So now, there's no major changes in this policy, but we do want to take a pause here. And we want to go through needle thoracostomy again. So unfortunately, we're still having some misadventures of needle thoracostomies in this county, despite our best effort at training and education. I'm going to drop this video address, a URL. Is that what you call it? Is that what you young whippersnappers call that thing?
It's a
What's
link.
an URL?
It's a link.
It's a link.
It's a link.
Drop it a link, but you can't click on it because it's another YouTube video anyway. Just write this thing down and go to it. Anyway, so it's actually, I think, a pretty useful video.
Yeah.
It's one of the more popular videos I've seen on YouTube on this.
Yeah.
And it's our very own Dr. Schatz, who's a trauma surgeon at UC Davis, and Sam Brown, who's the fellow before Brianna. So, and what they're running through is the techniques, some of the techniques for doing this to prevent these misadventures. But since we have you, I thought we'd hand it over to you and you can talk through some of this.
Sure. So I think the first thing that we want to do is we just want to delineate between pediatrics and adults, right? So I think we've discussed a lot about this. I know right now I'm teaching at the academy and we're talking a lot about this. So for adults, the ideal position is going to be your 3rd or 4th intercostal space on your anterior axillary line. And so, there's a lot of ways to kind of mark that spot. Sometimes people will put their hand up there, put their fist into the armpit and things like that. So again, that is for the adults. Now for children, the ideal spot is going to be the 2nd intercostal space in the mid-clavicular line. So finding the clavicle, going in the middle, 2nd intercostal space, that's going to be where you're wanting to target for pediatric patients. And just to talk a little bit about it, with our decompression needle, and I think that they talk about this in the video as well. But so when you have your needle, right, a really good tool to use, and we do this in the hospital as well, is if you're advancing into a space that has air, if you don't have anything hooked up to your needle, or you even just have like an empty syringe, it can be kind of hard to tell if you're in the right spot or not. And so a tip or trick, I guess, that you could use is actually using a flush, and you could empty a little bit out of this if you wanted to. But the goal, or like the theory behind it, is that as you're advancing in with your needle and you're withdrawing back on your flush, while you're in skin and while you're in tissue, you're not going to be able to withdraw back on that syringe. But as soon as you hit lung or hit into the chest cavity, you're going to get air and you're going to see bubbles in your flush, and you're going to have kind of that release of the flush. And so that's a really good method to use to make sure that you're getting into the right spot. Because again, if you're trying to advance a needle and withdraw on your flush and you're in tissue, you're not going to get anything. And so that's a really good way to make sure that you're getting into the right spot.
Yeah, I think the big take homes there and the things that I've seen are higher is better. Mm-hmm. Higher is better on an adult in the anterior axillary line. The ones that we have seen are in the liver, the small intestines, And we're not making this up, folks. Like, it really happens. And so higher is better. You talked about a technique of a hand in an armpit and going for where the knuckle is. That kind of lines up where your knuckle, not their knuckle, and your hand, not their hand. So, so it kind of lines you up correctly. But I really like the idea of using the syringe, because then because that needle's really big.
Really big.
And on someone who is thinner, there are case reports of impaling the heart with this. And so when you get that flash of air, just like we do with starting an IV, you get a flash of blood, you go just a little further, and you're in the right space, you're getting air, go and advance catheter, you're good to go.
Yep.
So, quick reminder also on traumatic arrests to do it on both sides.
Both sides.
Right. And so measure twice, cut once if you're not. So, all right. But, the science geeky guy here, hi. There is stuff there's literature out there. There was publications recently out of the Trauma Surgery and Acute Care Open where they looked at how well do pre-hospital clinicians do this. And this is a really scary story out of a hospital that is in California, believe it or not in Sacramento, but where the providers were successfully placing these needles into the pleural cavity 27% of the time. Yeah. That's 1 in 4.
Yeah.
So we want to do better than that. We need to do better than that. And this is a really great technique. And again, I really encourage you to go to that YouTube video, watch Dr. Schatz go through the technique, talk about higher is better, watch Sam go through the placement of it as well. It's really going to help you. And then I think one last thing as a reminder, remember there's no major changes in this policy, but we wanted to use this as an opportunity to kind of go through it, is the transportation of a pediatric cardiac arrest, traumatic cardiac arrest. And really, it is a parent's, relatives, family's worst nightmare to lose a child, especially in a traumatic injury. We want, and this is not just we want, but the county wants, and our hospitals, our trauma centers, particularly UC Davis, wants all of these patients transported, all of them. And I get a lot of questions, why? Yeah. And the reasons why I didn't actually understand until we reviewed an MCI where we had several kids that had died. And it was the pediatric trauma surgeon that said it that just stuck in my head. He said, we are equipped to do this. This is what we do. We have social workers, we have individuals that are on staff that are specifically equipped to care for the survivors, the families that have lost this child. And so by transporting this child to a trauma center in a traumatic arrest, no matter what, it's going to give that family the first moments of healing, we hope. So this is 8068. This is general medical complaint, which, by the way, as we open the video, there's a lot of policies that were reviewed. Some of these have changes, some of them don't. This video is much more science and education heavy than our typical videos are. But I do want to just run through general medical complaint again. We had questions at the county meeting about why did we lose this altered level of consciousness policy, like where did it go, and now we don't really have anything. Well, all of that was really parsed out into other policies, like seizure and suspected narcotic overdose, things like that. So there is a section now in the general medical complaint that talks about altered level of consciousness for you. And the section highlights sticking to your mnemonic, AEIOU tips, which we all learned in our education in school, even this old guy way back when, literally AEIOU I am, which is really scary. But anyway, just to consider your other causes of altered level of consciousness, thinking through a big one, right? Elderly patients who are altered but not a stroke patient are
Septic.
Septic, right. Don't forget about sepsis, right? And so sepsis is one of those. So just remember to kind of be on a hunt and looking through the patient, considering your AEIU tips under general medical complaint when you don't have an altered level of consciousness that's a seizure, an opioid overdose, or something like that.
Yeah.
Okay.
Moving on to sepsis. So 8067, the sepsis and septic shock policy. Again, no major changes to this policy either, but I think just a couple of talking points that we wanted to hit. So from the emergency physician standpoint, I think that the pre-hospital kind of identification of sepsis and initiation of treatment being in the way of fluids has really improved, and it really improves the patient's overall outcome just in general. And I think that that's super important to talk about, and knowing kind of all of the things that you're looking for so that you can start that treatment and identify that as early as possible. And so there's kind of three core aspects, I guess, of sepsis. So first is going to be recognizing that this patient might be septic. And we're going to talk a little bit about that, and Dr. Mackey is going to cover a little bit of the science behind that. So the first is just recognizing, is this potentially sepsis? And then the second is going to be providing this patient with fluids, right? That's kind of a big thing that you can do for a patient who is potentially septic or on that way towards like septic shock, is giving them fluids. And that even includes your heart failure patients, your ESRD patients. It doesn't really matter.
ESRD.
End stage renal disease.
I got you.
Your dialysis
patients.
Your dialysis patients, where typically you would think like not to give them a ton of fluids, but in this case, it is pertinent that you do. And then the last is going to be, we'll talk about this after the science, but your pre-hospital or pre-arrival notification to the hospital. So why don't you talk a little bit about SIRS and what is SIRS and why should we care about it?
Thank you, ma'am.
You're welcome.
Sir.
Sir, will you talk about SIRS, please?
Sure,
Thank
absolutely.
you.
All right, so SIRS, Systemic Inflammatory Response Syndrome. It says it in the name. So when there's an insult to the body, be it trauma or infection or ischemia or malignancy, it creates this massive response by the body to wall off, control, and get around this problem that is threatening the health and the welfare of the body. And that is the inflammatory cascade that happens, and that's what leads to this SIRS. And SIRS is not sepsis. That's really, really important that we talk about. SIRS is the inflammatory response. It's some of the signals that there's something going on, that there's smoke but can't quite see the fire.
Yeah.
And then sepsis is when the actual infection is identified and is part of it. So almost all patients with sepsis will have SIRS, but not all patients with SIRS have sepsis.
Correct.
Which is a really, really important thing. So, what is it? Just to, again, this is a review. We get that this is a review. This is just our opportunity to teach. And so we're going to use the platform. But the body temperature greater than 38 degrees Celsius or less than 36, the respiratory rate is greater than 20, and the heart rate greater than 90. Those are physiologic responses to an inflammatory process that's going on inside the body. Now, those inflammatory processes cause a lot of damage.
Yeah.
They can cause damage in our blood vessels and in our organs, but the body is trying to get ahead of this thing. And so the treatment and pre-arrival notification is required when there's a patient that has a suspected infection. And just a quick reminder too, like, where do we find these? Where are the three most common? Because they really come down to like three.
Yeah, and I would say it's urine, like above all, in my opinion, but then also lungs, so pneumonias, things like that, and then skin, actually, especially in these elderly patients, especially in your patients that are in nursing homes, right? It's not something that you may always see, but will potentially see once they get to the hospital, because you aren't necessarily, turning them and taking their diaper down and stuff. But yeah, skin, urine, and lungs are kind of the top three. But I think that you should also consider it in patients who either have been around sick contacts, right? So you're going and they're like, oh yeah, so-and-so that I live with or so-and-so that I know is also ill, and now I'm having similar symptoms and they're meeting, these SIRS criteria. Or again, like when we're talking about the urine, someone who has a Foley in place, a chronic indwelling Foley is always going to be kind of a source of infection. Or someone who's already been diagnosed with an infection and maybe was previously started on antibiotics, and now all of a sudden they're either not getting better or they're getting worse. I think those are kind of some other ones to just keep an eye out for.
Yeah, and did we mention yet that older individuals that have
altered.
a nuance level,
Yeah.
that might be what, sepsis?
Yeah.
I don't know. We
Yeah.
might have mentioned
Yeah.
it, but if we didn't, forgive us.
Yeah.
And so, all right. So we have this suspected infection, and now we've got these other two things. And so this is where we're going to be getting into the criteria for calling a sepsis alert, which is one of the three pillars of this is identification, fluids, and then calling that pre-alert. All right. So if there is a suspected infection, plus you have this temperature, which you've taken, or their heart rate's greater than 90, or respiratory rate, but then we have these other things too. This is where systolic blood pressure comes in. Do not get hypotension confused in SIRS, all right? That's not part of the SIRS criteria, but it is part of identifying a person who has sepsis.
Correct.
So hypotension, and then also end-tidal CO2 is another one if their end-tidal CO2 is below 25. I always tell the firefighters in the academy the answer to the test for end-tidal CO2 is anything that is low.
Every time.
Right? Every time, right? The answer to the test is low, right? And so sepsis will cause a lower end-tidal CO2 as well. And so what's our treatment?
Yeah, so if you're identifying this patient who is meeting your SIRS criteria and you're concerned that they may have an infection, first thing you're going to do is get that IV started. You're going to give at least a 500 cc bolus, and again, this applies to your patients who are dialysis patients who have end-stage renal disease.
ESRD.
ESRD. Or even your heart failure patients, right? Because again, although they may be fluid overloaded or they may have a potential and easier time getting fluid overloaded, they are still intravascularly, their volume is low if they're fighting an infection. So it is important to give them fluids. And so you're going to start that, and then you're going to call in your pre-alert to the hospital, sepsis alert to the hospital. And I think just one other thing to talk about is if you have, for some reason, you are way out somewhere and you have a super long transport time and you have given up to 2 liters of fluids, so 4 500 cc boluses, and they're still not responding and their pressure is still low and you're concerned, I think at that point you could definitely consider some push dose pressors. So just another thought, because again, when patients come in, they meet SIRS criteria. Once we define that they are septic or even in septic shock, what are we going to do if they're not fluid responsive? We're going to put them on pressors and we're going to admit them to the ICU.
100%. All right. So everyone knows what to do.
Sepsis, very common.
Sepsis, very common.
Very common.
And take-home message, you're doing a great job.
Yes.
That was really the front-end
100%.
take-home message. Doing a great job. Keep doing what you're doing, but be on the hunt for those older folks with altered level of consciousness coming out of a convalescent home. They're probably septic. Go looking for those SIRS criteria.
Yeah. I think especially like the respiratory rate too.
Yeah, respiratory
That's
rate.
kind of one that is could be potentially pretty subtle, and that maybe we don't always look for or pay attention to, but if you have that plus one of the others, then sealed the deal.
And a hack for getting an accurate respiratory rate? End-tidal CO2. Gives you not only the accurate respiratory rate, but it also gives you the end-tidal CO2.
Yeah.
So if you're wondering how many times have I seen, the respiratory rate's 60, and they're sitting there going, it's like, that's not 16. Did you mean 61? I don't know. But anyway, all right, end-tidal CO2. Okay, let's move on.
Yeah. To be 80-30, so that's pain of a suspected cardiac origin. Again, no big changes to this one except for an addition to the policy, and that addition is kind of similar, and that's about the pre-arrival alert and information. So if you have a STEMI, in your STEMI pre-alert, if you could so kindly, please, include in your report the patient's name, date of birth, and or medical record number. And so this is kind of similar to the stroke alerts. And the reason for this is because you can have a patient who has a wildly crazy EKG or an EKG that's reading STEMI, but it could look similar to their last 5 EKGs, and you would never know that. And so kind of one of the big reasons, A, to be able to look at their prior EKGs and compare it, right? Do we need to activate the cath lab in this very moment to call everyone in from home? And then also just being able to initiate their care faster. So I know that I've talked with some of you guys about like coming in to the hospital and stuff, and you know, we doe the charts sometimes, and that is just not good for anybody. It's not good for them, it's not good for us. It just makes everything a lot more difficult. So these pre kind of arrival, if you can include that in your report, name, date of birth, and or medical record number, that would be helpful for everyone and just really make that team collaboration between you guys and us so much better.
Yeah, and I still get questions from the field that says, is it legal for me to talk about HIPAA information like a name, date of birth over the radio? Without going, this is not the place to go into that, but if you reach out to me offline, I'll send you the legal brief that was put up by Paige Wolfberg and Worth. It goes through the legal backing for that. But yes, the short answer is this is supported in the industry and also supported by the law community. So because it's in the space of patient care, and we are a shared venture in patient care. So sharing that information is totally good. Now, one last thing is, believe it or not, we're still getting aspirin documented in the wrong place, like in the narrative. Just so you guys know, like on the backside of the pre-hospital care report, all of these procedures are attached to actual numbers, to NEMSIS criteria, which is the National EMS Information System, in California has their own. And this is how the state tracks data, it's how the LEMSA tracks data, it's how your agency tracks data. And if you put, hey, I gave the patient aspirin in the narrative, that it's like, it goes nowhere. So if you can just make sure that you document aspirin in the medications, that would be extremely helpful, because we know you're doing it. We have to go on a hunt for it, and it's just a quick reminder and to do that. So thank you, and again, thank you for everything you guys do as well. Thank you.
Yeah, no, thank you though, honestly. I love being a part of this organization. I love working with you guys. You guys are fantastic, but also like everyone in this county, whenever I get to see you guys come into the hospital, it just makes me so happy. So thank you guys for everything you're doing out there. Hopefully this was helpful, and we have a lot of fun making it for you. So
we do. We have a lot of fun, almost too much fun, actually.
Too much fun, I know.
But we will drop our contact information right here. I can do that on the backside.
Yes, you can.
To drop it right here. And if you have questions, never hesitate to reach out to us. We're pretty approachable. You can talk to us also at the hospital. I work at Kaiser South. She works at UC Davis. So the chances that one of you is going to see us is pretty high. So just ask us questions, and we will definitely see you on the next time.
All right.